Good evening, everyone, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and the title of tonight's program is Transformative Treatment Results in Plaque Psoriasis and Psoriatic Arthritis. As moderator this evening, we have Dr. Jordan Talia, Assistant Professor of Dermatology, Director, Complex Medical Dermatology, Director, Skin of Color Center, Kimberly and Eric J. Waldman, Department of Dermatology, Mount Sinai, New York, New York. As speaker this evening, we have Dr. Marc Serota, practicing physician, Peak Dermatology, Littleton, Colorado, CEO, MD Integrations, and Quadruple Board Certified Dermatology, Allergy, Asthma, Immunology, Pediatrics, and Obesity Medicine. We would like to thank our supporter this evening, UCB, for making this educational program possible. A couple of logistic tips before we begin. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and it will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill in this short survey. And also within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. At the end of the program, we will have an interactive Q&A session, so please submit your questions using the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Talia.
Thank you so much for that introduction, Ashley. Well, it's a pleasure to be with all of you today. I'm speaking on behalf of Leon Kircik, who all of you know is the president of the International Dermatology Education Foundation. As a reminder, the IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. And for all of your awareness, some previous educational sessions, as you can see here, there's 4 listed. Some of it's talking about immunodermatology, topical steroid application, vitiligo treatment, and using JAK inhibitors such as Olumiant and alopecia areata. Here's a way that you can stay up to date and connected with us through the IDEF educational webinars, as you can see here through Instagram, LinkedIn, and Facebook. And without further ado, I'm honored to be able to introduce to you our expert speaker, Dr. Marc Serota, who will be speaking with you transformative treatment results in plaque psoriasis and psoriatic arthritis.
All right, thank you so much. Thank you for the invitation to have me tonight. Again, my name is Marc Serota. I'm a dermatologist in Denver, Colorado, in Littleton. And before dermatology, I actually did a pediatric residency and then an allergy immunology fellowship, and then I did a second residency in dermatology. So that's really the reason I love speaking about inflammatory skin conditions, the immune system, skin disease, how those things overlap. So I'd love to give you a little overview on Bimzelx tonight, and hopefully turn what I think can be labor of love visits where you walk in the psoriasis room, a person has a story to tell, usually they're not doing procedures on them, and then you have to do paperwork, try to get treatments approved. I try to turn them from labors of love into fun, engaging visits where you get to stay on time with your day and the patient gets the information they need. So I try to do that with some analogies and some pearls, some highlights. So maybe that 5 to 10 minute conversation turns into a 2 or 3 minute conversation. And I think in the psoriasis world, the question always becomes, what am I going to present first line? I can't present 10 different options to patients. So what am I going to present to a patient for what I think are now sort of splitting hair reasons? So we acknowledge that all of the different psoriasis treatment options are fairly good options for patients that we have experience with in dermatology, but I can't present, a dozen different medicines. So what makes Bimzelx unique, and why do I present this as a first-line option to patients? Hopefully, if I do nothing else during this talk, I'll explain to you what those points are and why I present this as an option to patients when I first see them for psoriasis. So with that, we'll get started with the talk. And I'm speaking on behalf of UCB, which means I'm being compensated for the presentation. It's an educational, for this educational presentation, and I have to stay on the FDA label. So feel free to ask any questions that you may have. I'll try to answer them after the talk, at the end of the talk, but for the purposes of the talk, I have to stay on the FDA label, and I'm speaking on behalf of UCB. So we're going to go over a few things about Bimzelx that I think make it unique. But one of the take-home points, I think, is efficacy. And all of the drugs have a certain degree of efficacy, but I think when I say that, what I mean is we're redefining what we mean as success for a psoriasis patient. So the gold standard was PASI 75, and if you get a 75% on the test, I think of that as like a C. Like, why are we shooting for 75%? That doesn't seem quite good enough to me. And I'm not going to show you a single PASI 75 in this talk. We're talking about PASI 90, PASI 100, hitting home run balls and grand slam balls for patients. And with Bimzelx, that is very attainable. And you might say to yourself, well, I already know about IL-17 blockers, so why would this be redefining efficacy? And I'll show you why, because this is not blocking IL-17 alone. That sort of simplifies the actual situation with the cytokines, so we'll go over that. So I think the way we sort of think about this is rapid, complete, and maintain. Rapid meaning how quickly can we get people better? Complete meaning how completely can I treat their psoriasis? Can I really make their psoriasis disappear? And then can we actually maintain those results over time? So just with the first dose of Bimzelx, 4 weeks into it, which means they've had one dose, the average PASI improvement for those patients was 80% plus. So I said I wouldn't say any PASI 75s tonight, but just the average PASI improvement after one single dose of Bimzelx was above 80%, which means you already achieved the old endpoint just in the first 4 weeks. About 2/3 of patients, 60%, achieved PASI 100, which means total complete response. And of the patients that achieved PASI 100, 73% maintained that out to 4 years of long-term data. Similar story with joints. So Bimzelx is also FDA approved for psoriatic arthritis and psoriasis, around 40% achieving an ACR 20 after just the first dose. In terms of complete, 76% of dactylitis patients and 50% of enthesitis patients achieved complete resolution, and over 50% that achieved an ACR 50, which is, the old standard again was ACR 20, this is ACR 50, maintain that out to 2 years of data. So this is the first and only biologic that targets both IL-17A and 17F. So we used to say, there's 3 categories. There's TNF blocker, IL-23 blocker, and IL-17 blocker. But in actuality, we were oversimplifying it when we said IL-17 blocker, because the IL-17 cytokine actually has several different subtypes. So not just IL-17A, but also 17F. So if you say, what is more abundant in a psoriasis plaque, 17A or 17F? It's 17F by a wide margin. So we were blocking A, but we were ignoring the fact that F was actually the primary signal in terms of volume of cytokine in a psoriasis plaque. So the way I explain this to patients is I say your immune system in your body is like the military. You have the Army, the Navy, the Air Force, the Marines. Occasionally one part gets it wrong and it starts attacking something that's a normal part of your body. Those are the autoimmune diseases. Or starts reacting to something that's a normal part of your environment. Those are the allergic diseases. When that happens, what we want to do is jam the radios of just that battalion that's getting it wrong. So all the soldiers are still there. They're waiting to make an attack, but they never get the go signal because we're jamming their radios. I think if you explain it that way first, they're much more accepting of whatever treatment it is that you're recommending. But now let's look at what the actual scenario is here. So IL-17 cytokines down here are actually what's effectuating the phenotype of psoriasis. So you can block TNF further up the pathway here, but you're also affecting other things in the immune system. You could say, well, I have a lot of experience blocking IL-23, and I like blocking IL-23 because it prevents the Th17 lymphocytes from producing IL-17 cytokines. So wouldn't that be a good way to go? Well, the answer would be yes, if this was the only pathway that resulted in the production of IL-17 cytokines, but it's not. There are other IL-23 independent pathways, like the innate lymphoid cell type 3 and others, that produce IL-17 cytokines independently of this IL-23 pathway. So in my analogy, if this is the military, and this is sort of the chain of command here, this is like the local police force, and it's surveilling the tissues locally and also responding to what's happening here and creating IL-17 cytokines independent of this IL-23 pathway. So then you'd say, well, I want to block the radio signal furthest down here, so it's the most specific. Should I block 17A, 17F, or both? Well, ideally, we'd like to block both, because 17F is more prevalent. 17A is more inflammatory. So ideally, you want to block both and account for both. Some of the previous generations of IL-17 inhibition only block 17A, but it turns out that there's about 50% homology between those two cytokines, meaning if you find the right sequence on the cytokine and develop an antibody against it, you can simultaneously jam the radios and cell phones of this battalion in the immune system so that it no longer is able to create this phenotype of psoriasis. Okay, so that's what Bimzelx does. That's why I sort of think of it as a next generation 17, because we're not just blocking 17A, we're also taking into account that 17F is significantly more prevalent in psoriasis plaques compared to 17A. So how much more prevalent is it? 17F can be 30 to 50 times higher than 17A in inflamed tissues, like psoriatic skin lesions, also like psoriatic joints, also in other inflammatory skin conditions like hidradenitis suppurativa, for example. And those are 3 of the indications that Bimzelx is now approved for, and they have a total of 5 indications in the autoimmune world. So that's what Bimzelx does. And all of that makes sense immunologically, but now let's see how that actually translates when we look at the studies with patients. And again, I acknowledge the fact that all of these biologic medications have revolutionized the way we treat psoriasis patients, but which one am I going to actually recommend to a patient? I only get one chance to make a first impression on the patient and make them happy. So whether or not they've been on other therapies or not, if they're treatment naive or if they've been on other biologics, Bimzelx is something that I present to patients as a first-line option. And this is one of the reasons why. When you look at the studies with Bimzelx, 36%, about a third of patients had prior biologic experience, half being IL-17s, 42% TNFs, 16% IL-12/23, and 14% IL-23. So pretty even distribution there if you add up the 223 numbers. So the take-home point there is Bimzelx is its own animal. Just because they failed or were on another biologic does not mean they would or would not respond to Bimzelx. So now let's look at, okay, how am I going to make a good first impression on people? Well, like I said, depending on which study you look at, about 80% improvement in PASI score on average after just 1 dose of Bimzelx. So here is a splitting hair point of Bimzelx versus the competition. One is the average PASI improvement with just a single dose. The second is they actually did head-to-head studies against all these other drugs. So you have 83% versus placebo, 11% placebo. 47% did that with ustekinumab versus 83% with Bimzelx. 60% with adalimumab. You'll notice there's more doses, but it's still lower efficacy. And then even with 4 doses of secukinumab versus a single dose of Bimzelx, 72% achieved that versus 80% with much less injections with Bimzelx. So what about PASI 90? When I said we weren't going to talk about PASI 75, how about PASI 90? About half the patients in these trials achieved a PASI 90 after the very first dose, somewhere between 36 and 45% here, achieving a 90% improvement in their PASI score. This is what I like to tell. Patients, because at week 16, this number is 90%. 90% of patients will achieve a PASI 90 at week 16. So that's why I tell patients, what can you expect from this drug? I want your skin to be 90% better at week 16, and you have about a 90% chance of doing that. And you could see, even after the first dose versus the competition, really no comparison here. So here's some before and afters. Again, this is week 0, then week 3. Week 0 and week 3. If you want to be someone's hero, take their scalp looking like this and put it looking like this after 1 single dose of Bimzelx in 3 weeks. Plus, I like sometimes using a sample. Let's get them better looking like this. They're much more interested in doing any paperwork that's required or being compliant with the medication when you show them results like this within the first few weeks of therapy. And if someone's asking you, hey, is this a new start or is this a continuation of therapy? Well, hey, they got a dose at week 0 as a sample in my office. I'm now wanting to continue their therapy and look how well they did. They're essentially psoriasis free after just 1 dose. So sometimes that's helpful to say this is not a new medicine anymore. This is a continuation of therapy, and they've actually already achieved efficacy. Here's week 0 to week 4, 68-year-old female, and then on the right-hand side, week 0 to week 4, 60-year-old male. Pretty game-changing for patients with psoriasis. And again, you don't get a second chance to make a first impression. I don't wait and do other things and then say, all right, if it doesn't work, then I'll reach for Bimzelx. I say, let's give this person the best chance of getting clear and staying clear as quickly as possible. And you can see the kind of results here. Here's a patient who has skin of color, again, week 0 to week 5, and then week 0 to week 12 here with some hand and foot involvement. So now let's look at week 16. I gave you the preview already. So this is PASI 90s, and depending on the study, it's somewhere between 85% and 91% achieving a PASI 90 at week 16. That's what I tell patients, 90-90. I want your skin to be 90% better at week 16. You have about a 90% chance of doing that. And you can see versus the competition, ustekinumab 50%, adalimumab 47%, secukinumab, even with 7 doses versus 4 Bimzelx, still Bimzelx is superior with half the number of doses, essentially. And around 2/3 of patients are going to achieve a PASI 100. So this is the grand slam ball, and you can see versus the other biologics here, kind of no comparison. Again, secukinumab being the closest with 7 doses at 49% versus Bimzelx with 4 doses at 62% at week 16. So again, this is why I reach for this as first line. So we talk about splitting hairs. We're talking about efficacy. We're also talking about having head-to-head data. We're having long-term data, and we're having 4-week data where patients are getting better within the first dose of therapy. So those are some of the splitting hair points of why I talk about Bimzelx with patients. Now, if we look out further, you could see these are the response rates at different points in time. And you can see at week 16 in this study here, 86% achieving a PASI 90 versus 62% achieving PASI 100 at week 16. So very similar to the data that we talked about. But now let's look at long-term, out to 48 weeks. Patients are maintaining these results over time, and contrast that in the pink with the secukinumab, which was the next best in terms of the head-to-head trials, but still not comparable to Bimzelx. And this is showing you PASI 100 maintaining those responses through 4 years of data. So even though this might be a newer medication to talk about with patients, this is really not new anymore. It's actually been used for many years, both in the US and abroad. It's just probably was a latecomer to the dermatology office, but you can see the kind of efficacy results that you're getting here by blocking both 17A and 17F. So you could tell patients, hey, we actually have 4 years of data showing these kind of results. And what you'll notice here is you see Q4 week dosing and then Q8 week dosing. So this is another splitting hair point. It's a really important point for Bimzelx, which is it's every 4 weeks out to week 16, and then you get to dose it every 8 weeks after that. So we used to think about IL-17s as once per month drugs. Now this is a once every 2 months drug to maintain this. Once you get this kind of efficacy, you can space it out to every 8 weeks instead of every 4 weeks. So that's another splitting hair point, is the person only has to do it 6 times a year every 8 weeks. So similar story for psoriatic arthritis. Now I know you're probably not primarily managing psoriatic arthritis as a dermatology practitioner, but around 30% of your psoriasis patients are going to have arthritis at some point in their disease course. And I don't want to even know which of my patients are going to do that. I just want to treat them with something that's going to prevent their joints from becoming permanently damaged from psoriatic arthritic disease. And I consider that when I put them on their psoriasis treatment as well. Some of the psoriasis treatments are better or not so good for arthritis. And Bimzelx, I think, really stands out in the same way it stands out with plaque psoriasis for psoriatic arthritis. Again, the rheumatologists were okay with 20% improvement in their ACR scores. And Bimzelx went for ACR 50 and even ACR 70. And you could see the kind of efficacy with almost half the patients getting an ACR 20 after just 1 dose of Bimzelx. This would have been a great primary endpoint for other drugs to say half the patients achieved ACR 20. I'm talking about that after just a single dose of Bimzelx. And even ACR 50, 18%, so 1 out of 5, got at least a 50% improvement in their ACR score with just a single dose of Bimzelx, which, if you're not that familiar with ACR, this is really, again, raising the bar of what we expect for efficacy with these drugs. So you could see then at week 16, this is around half the patients now are achieving an ACR 50, 44%. So that's what I tell patients, what can you expect from your joints? I want the scoring that we use, the ACR score, to be at least 50% better at week 16. You have at least a 50% chance of doing that. And again, you can see it, this tracks out over time, so that if patients achieve that, they're very likely to maintain it out to 2 years of data they're showing you here. And this is showing you ACR 20, ACR 50, and ACR 70, a 70% improvement in their ACR score. And you can see out to 2 years of data, 64%, 52%, 39% respectively for those different metrics. 64% ACR 20 score is really impressive in terms of what you see with other medications and looking at ACR scores. So in the same way that you would expect Bimzelx to raise the bar with efficacy for plaque psoriasis, again, I think based on both the mechanism and the actual qualities of the antibody, the same is true for psoriatic arthritis. So this is 100% resolution, meaning all of these things are completely resolved. So 77% of patients got no radiographic progression. So I always tell patients with your joints, we can push pause, we cannot push rewind. So I want to push pause as early as possible in your disease so that you don't have, your joints aren't stiff like this where you can't tie your shoes or, open jars anymore. 76% got complete resolution of their dactylitis, and 50% achieved complete resolution of their enthesitis, inflammation of the tendons, particularly the Achilles tendon is a common one. And you can see up to 50% no swollen joints, 46% resolution of nail psoriasis. So nails and scalp are particularly important to us because both nails and scalp are harbingers or precursors that the patient could go on to develop joint disease, psoriatic arthritis. So if I see scalp or if I see nails, I'm asking myself, why does this patient not need systemic therapy? Both because I want to pause their joint disease before they even know they have it, and number two, because it's very difficult to make nails or scalp go away with just topical therapies. So we have a drug that treats both really effectively, raises the bar in terms of what we're looking for efficacy and complete resolution of things. And then I always file away in my mind, the patients who have nails or scalp go in a special category for me, and I have to convince myself they don't need a systemic, not that they do need a systemic. So is this, what kind of experience do we have with Bimzelx? Over 40,000 patients treated worldwide. There's 11 phase 3 and 3B clinical trials across all the different indications, over 15 years of clinical trial experience. So again, this is not a new medication. This is something that we have a lot of data, a lot of trials on. And it's also approved, as I mentioned, for moderate to severe hidradenitis suppurativa. So you have plaque psoriasis, you have psoriatic arthritis, you have hidradenitis suppurativa. You also have a form of ankylosing spondylitis as well. So some of these are outside our specialty, but I think it drives home the point that the IL-17 cytokine is really central to various autoimmune diseases that involve inflammation. And that's really the take-home point from the immune perspective. And it's not enough just to say IL-17. You have to specify what are you talking about, 17A and 17F. Now let's take a look at the safety profile. So here are the different studies that we're going to talk about, over 8,000 patient years, 11 different trials between psoriasis and psoriatic arthritis. And this is the 1% slides. This is anything that occurred in more than 1% of patients in the trials. The take-home point here is a certain percent of patients, and you can look at the different trials, oral candidiasis is more common compared to placebo, and is more common than you would see with just blocking 17A alone. You still see it with the 17A blockers, but when you block 17A and 17F and you really effectively block this pathway, you get that amazing efficacy, and the trade-off is you might get a single episode of oral thrush. Okay, so when I was treating immunodeficiency patients in my immunodeficiency clinic in my fellowship, if someone came in and we diagnosed them as having an IL-17 or Th17 deficiency, the clinical manifestation of that was mucocutaneous candidiasis, because those cytokines are there. Just one of the things they help with is surveilling your mucosa for candida issues. So fortunately, your body creates this equilibrium state where most patients, if they get it, they get a single episode, you treat it with an oral antifungal, and that's kind of it, and it goes away. And the trade-off is they get to basically have their psoriasis disappear, or their psoriatic arthritis substantially improved, etc. There's nothing else that I really talk about here with patients. You'll notice another splitting hair point here, which is the injection site reaction rate. If you think about it, we have biologics that we very much like and tolerate with injection site reaction rates in the 10% plus range. Bimzelx tends to be very well tolerated with the injection site, and 2.7% injection site reaction rate is very manageable. 27 people out of 989 who were taking the drug in this data being presented here. There was a little bit of a bump in AST, ALT elevations, although you see that in placebo as well. So that's not really something I talk to patients about. And it's not something that was only around 1% of patients. And it's not something that is recommended that necessarily be screened for, but you should be aware of that if you come across it. And psoriatic arthritis data is very similar to this, so I'm not going to belabor the point. You will notice that the oral candidiasis seems to be less here, and that might have to do with the dosing, because this is 160 milligram Q4 week versus psoriasis where it's 320 milligram Q4 week. So if that was an issue, I guess you could consider this dosing, but because it's very easily treatable and still only 7% of patients or so were getting the oral candida, I don't routinely do anything other than just the FDA labeled dosing for psoriasis. But regardless, you can see the difference there when you look at the dosing. This is long-term safety out to 4 years of data. I think the take-home point here is there's nothing that's jumping out to me in terms of new safety signals that we need to tell our patients about. Specifically, people ask about suicidal ideation, etc. That's not something that's popping out here to me that I need to talk to patients about. I also will tell you that the IBD rates, the inflammatory bowel disease rates, seems to be lower than it is for other just IL-17A inhibitors. And I'm not comparing them because they weren't studied head to head, but generally the warning still exists about if not using IL-17 inhibitors if someone has Crohn's or ulcerative colitis. But if I did need to reach for one, and there are scenarios where you might need to consider that, it's not an absolute contraindication. If I was going to choose one, I would choose Bimzelx based on the data that I've seen with IBD. There may be something to the fact of blocking A and F where that particular gut issue that you see with the 17As alone doesn't seem to be showing up here with Bimzelx. Okay, so we talked about the candidiasis. 95% were mild to moderate. Only 0.7%, 15 patients discontinued due to the candidiasis. So the vast majority, it's going to be a single episode. It's going to be within the first 16 weeks, and you can treat it with antifungal therapies, either oral nystatin, swish and spit, or just a dose of oral fluconazole, just as you would routinely for a woman if they got a vaginal yeast infection, for example. And with prolonged Bimzelx exposure, this decreases over 2 years. So that's generally how I think about it. It's rare that you would have to take someone off because of this. You just have to educate them. If they get it, we're just going to treat you, and that's it. People have asked me, do you just prescribe an antifungal for someone when you put them on Bimzelx? No, I mean, it's not everybody that gets that. It's around 7% or so, 7.5% like we talked about. So if it's an issue, they let me know that, but I don't routinely prescribe that for people. So I think we talked about all the indications. I went over suicidal ideation and behavior. Because they did see behaviors like this, even though it was still in the placebo range, that's why this warning is on the package insert. But there's not a causal association between Bimzelx and suicidal ideation, nor is there any black box warnings about that. So it's not something I really discuss with patients, other than just to ask patients how they're feeling in general, because all psoriasis patients could have an increased risk of mental health issues or depression and things like that. Obviously, if someone gets an active infection with something, with any of the biologics for psoriasis, you're going to consider holding their biologic if it's something more than a cold. That's basically what I tell patients. If you're getting a cold type thing, not a big deal. If you have an infection that's something more than just routine cold stuff, let me know. We'll probably hold the dose if we need to. And then you're supposed to evaluate patients for TB prior to initiating Bimzelx. That's pretty standard. I talked about liver already. I talked about inflammatory bowel already. You're supposed to get all age-appropriate vaccines. And we talked about the common adverse effects when we looked at that 1% table, but they list them here again. Okay, so in terms of dosing, again, that's another splitting hair point that we talked about, is don't think about 17 inhibitors anymore as once per month. It's once every 2 months. There is a syringe and a pen, and it used to be that they only had 160 milligrams, so you had to give 2 pens or 2 syringes to get to the 320 dose. Now they have a 320 pen and a 320 syringe. So it's truly 1 injection once per month for 4 months. And then after that, it's going to be once every 2 months thereafter. So very easy to do. And if someone has psoriasis and psoriatic arthritis, you're going to go for the 320s. You really wouldn't use the 160s. That's something that the rheumatologist would use if they were using it for a rheumatologic indication without any history of skin disease. Okay, so again, this is the dosing. I already went over it, but I will note that if your patient is over 120 kilogram, which is about 250 pounds, then you would consider keeping them every 4 weeks instead of going to every 8 weeks. You still could go to every 8 weeks, but the recommendation here would be to keep them at once per month. So everybody else is going to be once every 2 months. That's how you should think about this drug. But there is a scenario there where if someone is over 120 kilograms, that you would keep them once per month. In terms of coverage, it's really a non-issue for commercially insured patients, just like the biologics you're used to. I tell patients either for private health insurance patients, I say either your insurance is going to cover this or the company that makes it is going to cover it for you, but you should not pay anything significant out of pocket. And if their insurance is not covering it or pending things, they go into that bridge program where UCB covers it for up to 2 years. The other thing I really like is they have this nurse navigator program. So it's a nurse who can help them with medical questions in terms of how to inject and things like that. But they also help them navigate the insurance process and make sure that they're actually able to access the treatment. So again, I always tell people when they ask me about access, I just say, if the insurance company says they can't get a drug, that means nothing to me. When your local rep says they can't get that drug, then I actually believe that they can't get that drug. Usually it's just there's some administrative issue or something you didn't document that is the reason that they couldn't access it for some reason. But in the meantime, because this drug is so infrequently dosed and of how effective it is, it's a great opportunity to start with a sample, get them feeling better, get them bought in, and then by the time you get the paperwork, you might just be able to say, this person is already better. They've already achieved a PASI 90 response. I don't want to switch them now. Like this is clearly working for them, and this is the drug that's best for them. But even if the insurance disagrees, UCB is still going to cover it for the bridge program. So here's a little bit more about the savings and bridge. You can read about these a little bit on your own, but essentially that's what I tell patients is if you have private health insurance, you should not pay anything significant out of pocket for this, regardless of what else you are on or regardless of what your letter your insurance company might send out. So I know not everyone's going to remember everything from a talk. I wouldn't expect you to. If you could take home a few pearls, I think the things I would want you to remember, I want you to remember an efficacy number. I want your skin to be 90% better at week 16. You have about a 90% chance of doing that. I want to remember safety, no black box warnings, somewhere between 7 and 10% oral candidiasis. If they get that, we're going to treat them. Most patients, it's going to be a single mild or moderate episode. And then I'd like to remember the splitting hair points. So what are the splitting hair points? Once every 2-month dosing after week 16. I want to remember all the head-to-head data I showed you against all the different classes of cytokine. What makes this drug unique? It blocks both 17A and 17F. Why does 17F matter? Because it's in plaque psoriasis 30 to 50 times more abundantly than just 17A alone. Why don't I want to block IL-23 instead? Well, I still have the other local police force who's still coordinating attack and responses outside of the normal IL-23, Army channel. And then lastly, if you could remember the military example, how does this drug work? It jams the radios and cell phones of the cells that are triggering your psoriasis. So we're not blocking your immune system's ability to function in general or targeting a specific battalion to try to stop it from inappropriately creating inflammation in your skin. And that's why they say transformative here with A and F, so you can remember that. All right, so Benzellix, again, the first and only approved biologic that targets both of those cytokines. And then here is some resources. If you you can share success stories here with your peers. I believe patients can also upload before and afters. It's essentially a community where patients can learn and go to the website. So even if patients aren't ready to get started, which a lot of them are, I give them the handout and I say, this is what I'm recommending. Go home, read about this. Take a look at some before and afters online, read about other patients' experience. And then when they come back, they're much more motivated if they've done a little bit of shared decision making and looked at things themselves. So with that, hopefully I kept my promises tonight to try to make these visits with your plaque psoriasis patients a little bit more efficient, hopefully give you a few analogies and pearls so when you are presenting what psoriasis is in general, but also how Bimzelx works and why you're recommending it to a patient. Maybe there's an analogy or a pearl in there that helps you do that a little bit more efficiently so that, again, your patient gets the information they need, but you also get to stay on time with your day and hopefully, I think there's not too many things. I think Dr. Talia would probably agree with me. There's not too many things in dermatology where you really get to be someone's hero and really kind of change the way they view themselves in the world. Probably isotretinoin and acne, the biologics for atopic derm now, things like that. But certainly the biologics for psoriasis is something where it's really gratifying. We're almost standing on the shoulders of the pharmaceutical companies and just kind of taking a little bit of the credit because we're the ones that are recommending this to patients. And when you give someone a PASI 100 2/3 of the time at week 16, it's kind of like they'll tell all their friends, what a great dermatology practitioner you are, and kind of raises your profile in your community as an expert in that area. So thanks again for having me. Thank you for listening. And we have a little bit of time, I think, for questions, if there are any questions. Thank you.
Awesome. Thank you so much, Dr. Serota. That was a fantastic presentation, review of all the safety data and then patient access information. If you do have questions, as Dr. Serota mentioned, please feel free to use the right-hand side panel and you can share some with us. Question I have for you, Dr. Serota. So when you're starting patients off on Bimzelx, whether they're naive or perhaps not, can you walk through how you go about the lab monitoring process, whether before they start the biologic and or while they're on it?
Yeah, so the recommendation is to check the TB test. Well, it's to screen for TB technically is what the verbiage actually is. So if someone is very low risk for TB, they've lived in metro US for their whole life and they are not at high risk for TB, theoretically you wouldn't necessarily have to test them. You'd have to screen them for the possibility of TB. But in practicality, I think most of us are going to place a PPD or do a quantiferon gold. And the other thing I'll say is, if you're going to check a quantiferon gold, that means you're drawing blood anyway, and then I think it's reasonable to check a few other things if you would do that normally. LFT being the one most common because that is called out in the label. But I say to myself, okay, if I'm drawing blood, if there's a reasonable chance they could have something else I would want to know about, like HIV or hepatitis B or hepatitis C, then I would just tell them I'm going to screen them for those things. But that being said, if they're low risk and you screen them, you can screening them for TB is what's required. The other things are sort of if you're going to go through the process of drawing blood. And then technically you only have to screen them for TB according to the label. But again, I think most of us are used to checking annually to update their TB status. But I think it's also reasonable to be a little bit practical there. If they have no exposures and they're not high risk, and there's no reason to suspect that, there's nothing in the label that mandates that you do those things. So part of it is the art of medicine and part of it is trying to follow the guidance of the label.
Awesome. Yeah, thank you so much for that overview. The other, I know, so there is kind of the weight-based portion of the label. Would you say a majority of your patients you do follow with treating them essentially every 4 weeks up until week 16, and then switch almost everybody to about every 8 weeks thereafter? Do you have any exceptions to that?
I do. With the label being what it is, if they're over 250 pounds, I will have the discussion with them and see how they're doing clinically and decide if you want to go to every 8 weeks or if you want to keep them at every 4 weeks. The other thing I'll say is obesity, and I'm board certified by the American Board of Obesity Medicine, so I like talking about this. Obesity in and of itself is an inflammatory condition. It's actually a very inflammatory condition. When you hypertrophy your adipocytes, they have relative necrosis because they don't have enough blood supply. When you multiply the size of your adipocyte times 5 because you're obese, adipocytes are an excellent source of inflammatory cytokines when they feel like they're under oxidative stress and they're being strained because they're necrotic. So I say that to say to the dermatology practitioner, if you have a patient that is obese or overweight with a weight-related comorbidity, they should be considered for therapies for that. Whether or not you're going to initiate them or not, a lot of our dermatology colleagues are getting more comfortable with things like GLP inhibitors. But even if you're not comfortable with that, just remember that if you have that metabolic syndrome patient or that obese patient in this as a psoriasis patient, you may not make them fully better like you expect by just targeting the cytokines if you don't turn off the faucet of where those cytokines are coming from. And that's separate from someone who's a normal body habitus who's genetically predisposed to psoriasis or psoriatic arthritis. So just, I would say, be cognizant of the fact of if you're looking at a psoriasis patient and they're a metabolic syndrome or an obese patient, consider what else is good for their health that's also going to help me treat their skin disease, yes, but I can also add 8 years of life expectancy if they're no longer obese. That's a pretty good thing to do for people as well. And you should, if you're not as familiar with GLP therapies and other obesity medicine treatments, it's a really worthwhile thing to do. And I'll be leading some of those discussions in some national meetings coming up here as well if people are interested.
Awesome. Thank you so much. That's a great point, particularly talking about the kind of inflammatory side of obesity. Last question for you. You touched upon, very importantly, kind of the candidiasis side of things. It's great to know in the clinical trial, there's very few discontinuations as a result of that. Can you talk about in your clinic how you tend to approach it when that comes up?
I think the easiest thing to do is just give someone a single dose of oral fluconazole, something like 150 milligrams of oral fluconazole. It's super simple. It's a single dose. We give it routinely for women when they get a yeast infection. For complicated women's yeast infections, you'll repeat it in 72 hours. So it's very, very easy and simple to do. So that's my preferred thing to do. If you want to give someone nystatin, swish and spit, you can do that. But swishing and spitting something multiple times a day and trying to be compliant with that and doing that for 5 consecutive, it's a little more annoying than just saying, just take this one antifungal pill and that's kind of it. So that's my preferred way of doing it, but you're not wrong if you just want to do nystatin, swish and spit instead.
Awesome. Thank you for that kind of that tidbit. That's very helpful. Well, with that, Dr. Serota, I want to thank you very much. I'd also like to give a thank you to our supporter, UCB, for their sponsorship of this educational discussion today. And again, Dr. Serota, thank you so much for your time.
Thank you. Thank you for having me.
With that, we'd like for all of you to stay up to date with the IDEF educational webinars upcoming. This will be next week, Tuesday, August 19th at 7 p.m., same time as today. Dr. Jason Hawks, Clinical Assistant Professor of Dermatology at the Oregon Health and Science University in Portland, Oregon, is going to talk about unlocking CSU, exploring the role of BTKs in pathophysiology, unmet needs, and disease burden. So we look forward to chatting with all of you then. Thank you again so much for your time today.